Hello everyone and welcome to our module on insulin. In other videos I talk about the differences between type 1 and type 2 diabetes, but you should be aware that type 1 diabetes is mainly treated with insulin, and that's because these patients lack the ability to produce natural insulin from the pancreas. In contrast, type 2 is treated with oral or subcutaneous drugs, sometimes with the addition of insulin but not always. Usually in the initial stages of type 2 diabetes, treatment is with oral drugs or subcutaneous drugs, and only when type 2 diabetes becomes advanced is insulin therapy required. So insulin is a naturally occurring hormone produced by the pancreas, but there are many different types of synthetic insulins that are available for use as diabetes therapy, and they all differ from one another by the time to peak action and the total duration of action, as well as they also vary slightly by their peak effect, meaning how much they bring down the blood glucose at peak effect. And so the forms of insulin that have the fastest peak of action and the shortest duration of action are called rapid-acting insulins. At the other end of the spectrum, insulins that have a very slow time to peak action and a long duration of action are called basal insulins. These can often be administered once per day and they will exert their activity throughout the day. And then in between the two extremes, there are forms of insulin like regular insulin and NPH insulin. And so in the next few slides, we'll go through all of these different types of synthetic insulin. To understand the different types of insulin, it helps to know about insulin hexamers. So insulin molecules like to form hexamers inside the body. A hexamer is 6 insulin molecules that are linked together, and this is a very stable structure. So insulin is usually administered subcutaneously, and when this is done, the activity of the synthetic insulin is related to the speed of absorption. And so if a synthetic insulin forms hexamers easily, this will lead to a slower onset of action because those hexamers are very stable and slow to be absorbed. In contrast, if a synthetic insulin stays in the monomer form and does not form hexamers, this will lead to a faster onset of action. And so this is a basic principle of insulin pharmacology and why some of the different forms of synthetic insulin have different properties. Let's start by talking about the rapid-acting insulins. There are 3 important insulins in this group. The first is called Lispro, the second is called Aspart, and the third is called Glulisine. And all of these are modified forms of human insulin. They are human insulin with modified amino acids. And because of the amino acid changes, these forms of insulin have reduced hexamer and polymer formation. So when they are administered subcutaneously, they are rapidly absorbed and have a fast onset of action but a short duration of action. So usually the onset is in about 15 minutes and the peak is in about an hour, and the total duration of action is about 2 to 4 hours. And because of these properties, these insulins are ideal for use pre-meal. Right before a meal, when there's going to be a spike in blood glucose after the meal, you want a short-acting insulin to prevent a surge in the glucose level and post-meal hyperglycemia. So if we were to make a graph with hours after administration of insulin along the x-axis and insulin effects along the y-axis, rapid-acting insulin would look like this line shown in blue, with a very rapid time to peak action and a total duration of action under 4 hours or so. Regular insulin gets its name because it's a synthetic analog of human insulin. Basically, it's human insulin manufactured by recombinant DNA techniques. So it has similar properties to naturally occurring human insulin. The onset of action is in about 30 minutes, the peak is in about 2 to 4 hours, and the total duration of action is about 3 to 6 hours. And so going back to our graph, regular insulin has the properties shown in red. You can see that its duration of action and time to peak is slightly longer than rapid-acting insulins. Regular insulin is the only type of insulin that can be administered as an intravenous medication. All the other synthetic insulins we'll talk about in this video are only given as subcutaneous drugs. But regular insulin can be administered intravenously, and for that reason it's used in the treatment of diabetic ketoacidosis and HHS, which I talk about in another video. You can also use intravenous insulin to treat life-threatening hyperkalemia. It's given together with glucose to prevent hypoglycemia, and this is useful because the insulin will cause potassium to shift into cells, and this will bring down the plasma potassium concentration. NPH insulin gets its name because NPH stands for neutral protamine Hagedorn, and it's called this because it's a regular insulin molecule combined with neutral protamine, which is an amino acid. And by adding neutral protamine to regular insulin, you slow the absorption. So as a result, NPH has the properties shown in green on this graph. The time to peak is about 8 hours or so, and the total duration of action is about 12 to 16 hours. And then the longest acting forms of insulin are the basal insulin analogs. These include glargine insulin, detamir, and degludec. All of these are insulin molecules with a modified chemical structure, and the goal is to provide a low-level continuous insulin effect to the body. The properties of the basal insulins look like the pink line shown on the graph here. You can see that their peak effect is much lower than other insulins, but their duration of action is very, very long. The onset of action for the basal insulins is about 2 hours, but the duration is up to 24 hours or more. Glargine and detamir have a duration of action of up to 24 hours, and degludec has a duration of action of more than 40 hours. And so because their duration of action is so long, these drugs are often given once daily. And the goal is to provide a low level of background insulin effects to the body. Just a brief word on the administration of the synthetic insulins. So as I said earlier, synthetic insulins are usually administered subcutaneously, but you should know that they can also be administered by continuous infusion via an infusion pump, like what's shown on the slide here. These are most often used in patients with type 1 diabetes who have no natural insulin production. They can be given an infusion pump which infuses rapid-acting insulin, and some of the pumps have become very sophisticated. They can actually estimate the plasma glucose through a sensor and adjust the dosage of insulin, almost like the pancreas would do naturally. Let's talk about hypoglycemia, which is the major adverse effect of all insulin regimens. Any of the insulin types we've discussed in this video can lead to hypoglycemia. When that happens, the early symptoms the patient will report are things like tremor, palpitations, sweating, and anxiety. These are all early signs of hypoglycemia. If the hypoglycemia becomes severe, patients can have seizures and even develop a coma. And so this brings me to an important point. In any unconscious patient, you always have to check the blood glucose level. That's because hypoglycemia is in the differential for loss of consciousness. And there are many patients in the US who take insulins for diabetes and other drugs that can lower the blood sugar level. So in anyone who is unconscious when you don't know the cause, you have to consider that they could be hypoglycemic. And in clinical practice, when patients develop episodes of hypoglycemia, they're often instructed to drink some juice or consume some type of sugar, and then the dosages and the frequency of their insulin regimen are adjusted to avoid episodes of low glucose. Another adverse effect of insulin treatment for diabetes is weight gain. This occurs in most patients who take insulin for diabetes therapy, and that's because insulin promotes fatty acid and protein synthesis, and so patients tend to gain weight when they are taking insulin for treatment of their diabetes. Rarely, patients who take subcutaneous insulin can develop hypersensitivity reactions. These are divided into two subtypes, immediate and delayed. Immediate hypersensitivity reactions are IgE-mediated type 1 hypersensitivity reactions. They are basically variants of the same process that causes anaphylaxis. And by definition, an immediate reaction occurs within 1 hour of injection of subcutaneous insulin. This can be a local skin reaction with features like erythema and wheals and pruritus, or it can be a systemic reaction with generalized urticaria and angioedema, and it can even progress to anaphylaxis. The treatment is similar to other forms of hypersensitivity reactions. It involves antihistamines and glucocorticoids, and if patients have evidence of anaphylaxis, they need to be administered epinephrine. Delayed hypersensitivity reactions, by definition, occur more than 1 hour after injection, and often they occur many hours or even a day or more after injection. These present as things like induration or nodules at injection sites, or they can present with features of contact dermatitis, which looks like poison ivy. And the treatment for delayed hypersensitivity reactions is with topical corticosteroids. And then lastly, subcutaneous insulin injections can lead to subcutaneous fat changes. One of the things that can happen is called lipohypertrophy. This is swelling of fatty tissue at injection sites. And this occurs because insulin alters fatty tissue growth. So that can look like a lump where the insulin is being injected, like in this picture on the screen here. Another subcutaneous fat change that can occur from insulin is lipoatrophy. This is loss of fatty tissue, and that will look like this picture here where this man has a depression in the skin at sites where he's been injecting insulin. And so to prevent patients from developing subcutaneous fat changes, they're advised to rotate their injection sites. Usually these changes only occur after multiple injections in the same site. And that concludes our module on insulin.